Good afternoon, everyone. My name is Dr. Ratna, and I represent an organization called Patient Academy for Innovation and Research. We are a regional organization, and we represent patients and patient advocacy in the region. One of our flagship programs is working on patient safety. As you know, World Patient Safety Day is an annual event that is commemorated on 17th of September every year. World Health Organization designates a thematic area for World Patient Safety Day. This year, the thematic area is improving diagnosis for patient safety with the tagline, Get it right, make it safe. We know that diagnosis is the bedrock for a proper treatment. And unless an accurate diagnosis is made, the patient will lose the opportunity to have a proper treatment in time. So today's thematic area for our webinar is ensuring accurate diagnosis, a collective journey towards excellence in patient care. Since we are a patient organization and we believe that patients are equal partners in their care journey, we feel that educating patients and the stakeholders that are involved in the diagnostic journey is equally important. To join us today on this webinar, we have 6 excellent speakers, and it is my pleasure to welcome them and introduce them at the beginning of this webinar. Can I have the agenda back, please? So I will be giving an overview of the World Patient Safety Day and kickstart this webinar. And we will then follow by the session chair and the guest of honor, who will be speaking about the theme of 2024 World Patient Safety Day and the work that has been done in India. We will follow that with a keynote address on why is diagnostic safety so important for patients and families. And then a panel discussion with 3 speakers on perspectives from a policymaker, perspectives from a patient organization representative, and perspectives from the healthcare provider. We will be wrapping the webinar up with case studies from 2 patient advocates, and then we will have the closing remarks from the chair of the session. So World Patient Safety Day, as you know, is following a resolution that was passed in 2019. And following that, every year we have several events that span across the month in September to commemorate World Patient Safety Day. Vikas, can I have the introductory slides, please, while I introduce? So, and every year, Patient Academy for Innovation and Research has been following the theme set forth by the World Patient Safety Organization. This year, we had 6 webinars previous to or preceding today's event. And these webinars focused on the various roles and responsibilities of various stakeholders, as well as what could be done to improve diagnostic safety. This is of very great importance, especially in countries like India, where we have a mix of the public and the private sector. And very often the private sector is not regulated as much as it should be. So today's webinar hopefully will throw some lights on what are the problems and what are the gaps in diagnostic safety and how can we jointly as various stakeholders from the system address these gaps. I will start with introduction of the session chair and the guest of honor, Dr. K. Madan Gopal. Welcome, sir. Dr. Madan Gopal is currently serving as an advisor, Public Health Administration at the National Health System Resource Center, Ministry of Health and Family Welfare, Government of India. He continues to play a significant role in advancing public health administration in India and is a distinguished health professional with over 30 years of experience in advancing health system reforms in India. He has contributed extensively to various policy initiatives while serving as a senior consultant at Niti Aayog, that is our think tank, supporting critical health sector reforms, and he has been honored nationally for his remarkable contributions to healthcare. Welcome, sir. And I will move on to the next introduction. If I can have the next slide, please. Our keynote speaker today is Mr. Manvir Victor, and he is a former renowned radio DJ in Malaysia, becoming a patient advocate after experiencing kidney failure, 10 years of dialysis, and a successful organ transplant. He is a founding chairperson of Patients for Patient Safety Malaysia with over 6 years of experience in consulting healthcare organizations on patient integration. He is a member of Malaysia National Patient Safety Council, WHO Global Advisory Group on Patient and Family Communications, and British Medical Journal's Patient Advisory Advocacy Panel. He hosts and produces the podcast Healthcare Today with Manvir Victor, which is hugely popular, and is a strong advocate for healthcare providers to listen to patients and with compassion to build trust. Thank you, sir, for joining us on today's webinar. Can I have the next slide, please? It is my honor to welcome Dr. Piyawan Limpanyalert. She is the Chief Executive Officer of the Thailand Healthcare Accreditation Institute and is an obstetrician and gynecologist doctor for more than 10 years in the community hospitals to general and university hospitals. She is also the development expert and supports the hospitals to continue developing using the concept of quality development and patient safety to integrate within hospital standards and hospital accreditation and organizing, establishing a platform for sharing and learning for the healthcare system to identify good practices. Through these programs, key stakeholders, including patients and families, are engaged as active partners in nationwide movement to improve patient safety. Welcome, Dr. Piyawan. Can I have the next slide, please? It's my honor to introduce Ms. Sairekha Sureshkumar. She is a lawyer by profession and is dedicated advocate for the rights of individuals living with type 1 diabetes, also a trustee at the Type 1 Diabetes Foundation of India. She has been living with type 1 since 1996 and is based in Mumbai. Professionally, she is a lawyer specializing in workplace discrimination. She is one of the founders of Club 1 KEM, a patient healthcare provider ecosystem for T1Ds in Pune, her hometown. And in addition to her legal work, she actively engages in conversations with regulators on issues such as disability status, insulin pricing, and access to medication. Welcome, Ms. Sairekha. Can I have the next slide, please? It is also my honor and pleasure to introduce Ms. Janis. She's an advanced practice nurse for the past 10 years and currently works in National Neuroscience Institute, where she provides expert care to patients with neurological conditions in the outpatient and community settings. Her training and experiences allow her to conduct assessments and develop individualized plans and management to ensure optimal patient outcomes. Janis believes in patient advocacy and has assisted in the setting up of Multiple Sclerosis Society in Singapore. Welcome, Ms. Janis. Thank you for joining us. Can I have the next slide? I now have the pleasure of introducing Ms. Arshia Bhandari, who's been in the field of pharmacovigilance and drug safety for the last 18 years. She is also the founder of PhVFIT, an initiative to bring positive transformation in healthcare system by empowering patients and healthcare professionals through an understanding of patient safety, principles, and challenges. She is an ISQA certified in medication safety and recently completed Master Trainer certification in healthcare communication from IHM. She's been invited as speaker to various forums, including PVPI Program of India, ISCR, which is the Council for Clinical Research, the All India Institute of Medical Sciences to deliver tasks on patient safety and pharmacovigilance. She's also a certified business storyteller and coaches not-for-profit organizations on storytelling for impact. Welcome, Arshia, to our webinar. Can I have the next slide, please? And last but not the least, welcome Clarinda to our webinar. She is a UPATI certified patient expert and India ambassador for Sumera Foundation and a Stanford certified design thinker. A staunch patient advocate living with rare disease, she serves on the board of directors of the Global Patient Advocacy Coalition and on the management committee of the UK-based Rare Disease Research Network. Over the past 2 years, she has served at the World Health Organization as a consultant in outreach and stakeholder engagement. She cares deeply about patient engagement and co-hosts the podcast Not Just Patients, through which she aims to amplify the patient voice and break barriers to meaningful patient involvement in healthcare. This podcast is very hugely popular and I invite you to listen to it. It's fantastic. So thank you, Clarinda, for joining us today. It's my pleasure now to hand over to our chair, Dr. Madan Gopal, to give his opening remarks and set the context and have the webinar open. Thank you so much and over to you, sir.
Okay, thank you, Ratna, for this kind introduction, humbled by all these things. But one of the important things and the areas which we have highlighted many years, every year we celebrate this, we observe this Patient Health Safety Day. It's just a event which we are organizing, but can't we think that it becomes a year-round activity? Because having worked at the policy space, uh, in the apex policy think tank of the country, wherein we were writing policies, but the patient support groups most of the times were not there. So that's the status which we are seeing. But nevertheless, as we are maturing in providing healthcare and devising policies and other things, we increasingly feel that the patient support groups are very much required to at least bring in the perspective from the patient side. This year, theme is also targeting that how the diagnosis and the diagnostics, the diagnostic error can result in a catastrophe to a family or not. While one way we are talking about how to provide the best quality of services to the people and the patients, and the other way we are also worried about the safety of the patient. If you talk about any of the standards, the ISPA standards and the NA-based standards in India, they are all devised from patient safety point of view. But nevertheless, when we are devising the standards, where are the patient groups, how they have contributed? That's a question which we need to ask, and we have to ponder on that. So that's one of the things. So this year theme is very apt, that is errors in the diagnosis. I'm just citing an example. We are having a sickle cell disease control program that has been rolled out at the national level, wherein mass screening is happening. And if you look at the activists who are working, one of the activists when I interacted, he mentioned that due to faulty diagnosis, because he was carrier and he married to a carrier and their children are sickle cell disease. So you see that how an error in the diagnosis has resulted in a child, they have to take care of that child for the till the time, whatever time he's having. If that error in the diagnosis is not has been corrected at that time, informed on time, then he would have married a normal child, normal woman, or a normal person, and that kind of event, which eventually resulted in a sickle cell disease, would have been avoided. This is one example. Other example is you see the TB control program. When I was NITI, I did one study which focused on how many checks a person requires to land at a proper place. For tuberculosis, it is a Delhi study in which for reaching to the right place, I had to visit five to seven, around seven institutions before I came to the right place. At that time, I was detected as a multi-drug resistant tuberculosis. Ultimately, the patient survived, but after 2.5 years of treatment. If a diagnosis and other things have been properly happened at a proper place, then this would have been avoided. So the theme of the World Patient Day this year is how to identify the errors and how to address these errors. For addressing these errors, we have to see that what is the requirement, because we have to come back to the basics. Previously, when we used to be in the medical school, we used to study the Hutchinson clinical methods, wherein we talked about the importance of history taking and discussion with the patients. That was taught. And somewhere, as you look at the Harrison textbook of medicine in the coming years, the chapter on the laboratory and the diagnostics is increasing and adding on. And the clinical aspect, the history taking and the interaction with the patient is more or less the same. It has to increase. That means if you want to reduce the errors, you have to see that how we interact with the patient, discuss with the patient, pros and cons of going for the diagnosis, what is the accuracy of the diagnosis. If with one test, if you are not able to get the desired result, what is the other mechanism? That kind of consultation and counseling has to happen before a diagnostic session. But in India, we deal with numbers. We have to cater to the health services of 1.4 billion population. And people will tempted to say that they don't have time for counseling. Why? Because if you look at when we were doing in the medical college, a patient used to enter into the ward for treatment of malaria, but he is discharged on anti-tubercular drugs. He comes as a fever of unknown origin. First, he is put on malarials, then, but that used to happen around 20-25 years now. But similar practice still exists. That's why the importance of patient safety and error in diagnosis is very important. Otherwise, it would be just hit and trial method. I will give you malaria, I will give you anti-typhoid medicines. Then ultimately, if nothing is found, then I will put you on anti-tubercular drug, and the patient has to receive anti-tubercular drugs for 6 to 18 months. That is the story which goes on and on. So, other thing which has been highlighted in this year's theme is how to discuss with the patient about the options which are available, so that the errors in the diagnosis can be reduced. Why we want to reduce the errors? Because if you look at the study, because WHO and the other agency, they usually talk about catastrophe health expenses, and one of the catastrophe measurement of catastrophe health expenses is out of pocket expenses. In India, when we have studied it, we have found that drugs and diagnostic, they comprise a major chunk for this out of pocket expenses. And if an error in diagnosis happens, this add to the further catastrophe. Every year, around 10 million people, they shift from one strata to the other strata. That means from upper quintile of the income to lower quintile of the income they shift. That means that's a too much catastrophe unless we see that this error due to diagnosis is there. The other example, before I invite Manvir ji to share his perspective, uh, I just cite an example in the peripheral side. What happens if a person is detected having cancer and is referred to an advanced cancer center, and they run a battery of tests and say that you don't have cancer. So as a result, what has happened, the catastrophe, the mental agony, and other things which have been created from the patient point of view, who is going to address that issue? And he is always shocked. He won't be able to come out with this shock. In the policy front, we do have a National Health Policy 2017, which talks about patient-centric healthcare services, which has been to be provided. For the safety of the patient, we have a National Accreditation Board for certifying hospitals, where NABH standards are there. It talks about standards, processes, but nevertheless, all the standards, they talk about the safety of the patient, but nevertheless, nobody discusses about the safety of the patient. If you go to any certified hospital, you have to find that how to engage with the patients and talk about the safety key if a procedure is done and what is the safety aspect. Another aspect which is upcoming is hospital acquired infection. If the patient is made aware that this healthcare acquired infections can also be a possibility, then they are prepared accordingly. So nevertheless, a lot of work is to be done, but important thing is engaging with the patient support groups in informing the policies. Even in the hospital acquired infection, if a hospital committee is there, if the patient support groups are there, so if they are engaged, then definitely they will tell that how to contain the infections. Before I close my opening remarks, I will just cite examples wherein when I visited Latin American countries, wherein they engage with the patient groups, they talk about the plan, how to plan any procedures or anything. Even the communities are involved, and the informed decision is taken, and the results are very encouraging. So let me hear the other panelists, and then I will summarize afterwards. May I request Dr. Manvir, the introduction has been already given. So please share us your insights about the diagnostic safety, why it is so important for the patient and their families. Over to you, please.
Thank you so much, Dr. Madan. I hope you all can hear me clearly. Thank you so much, Dr. Ratna and your team at Pear Academy for coming across to do this with us today. I hope you can see everything quite clearly. Can someone just tell
Yes,
me? Okay,
we can.
fantastic. Okay, great. Once again, thank you so much, Dr. Madan, for setting it very succinctly for us to talk about here today. As we are approaching yet another World Patient Safety Day, and we're talking about diagnosis, I think my colleagues who will be on right after this will be delving into the how, the what, the when, and the where of diagnosis safety. But what I want to unpack for you here today is just the why. The why is very important. Some of the points that Dr. Madan had alluded to just now, and also in my experience as a patient advocate and traveling around the world, I have found that a lot of countries have similar issues, and it's so good to see the number of people coming from different countries who are on this webinar right now. And I'm sure that you all may be able to relate to some of these issues that you have. But what is very unique about it is every country has a different approach to solving those problems. And it's good to have an organization like PAIR setting up this webinar so that we can have that fruitful discussion after this to be able to understand how each and every one of us approach a problem in a very different way. So I just want to share with you some of the issues that obviously are very important for patients, for accurate and timely diagnosis, which are crucial for effective treatment and improved patient outcomes. That's where we want to go to right now. And obviously, the first point that we need to talk about is, of course, the precise diagnosis that lead to tailored treatments. These also reduce risk and improve the patient well-being. That we all know, right? It obviously prevents the disease progression and it stops the conditions from worsening by catching them early. Dr. Madan had alluded to malaria and how it was taken care of 25 years ago and the differences it is today. So we can see from that already there's one very good example. Then what comes out of this is obviously that patients trust the healthcare providers more, and that is what healthcare is actually delivering. It is that trust. What and it happens when there's timely and accurate diagnosis, and it leads to an improved relationship and obviously treatment adherence, because it is important that patients know that the doctors are doing their absolute best. They're doing everything within their power, and that breeds the trust that patients want. And at the same time, you know that with the patient, I'm sure all of us here who are clinicians, we look at a patient and I know that these particular patients are very compliant with what you guys are diagnosing and prescribing. Now, obviously, timely diagnosis reduces the healthcare cost, which is spiraling out of control in every other country. Okay. And it avoids the expensive treatment, and it results from, which comes from delayed diagnosis, right? Now, what else does it do? That it also prompts diagnosis that reduces patient anxiety and stress by enabling informed health decisions. Now, one of the areas that's is very close to me, obviously, and a lot of patients is the fact of the anxiety, the mental health, the stress. I mean, being ill is not something that we all set out or plan to be. But when we are ill, we need to be able to trust our healthcare. And what helps that trust is obviously someone who is able to take away that anxiety. That confidence comes from that confidence comes from you when you know that you are effectively practicing healthcare and medicine. Right. It also helps prevent misdiagnosis or overdiagnosis. This has happened in many cases, and it avoids the unnecessary treatment and their side effects, because the patient is the one who suffers all this. Can you imagine someone who is ill and then goes through misdiagnosis or overdiagnosis and gets even worse? So obviously, that is not what we set out to do. And as healthcare, we are trying to be as safe as possible. But having to do this on a regular basis means it's a teamwork, right? And where does that teamwork come is by having this personalized medicine, by tailoring treatments to the individual genetic makeup and health conditions. Now, I'm a kidney transplant patient, as you all know, and I know that, for instance, in the work that we have been doing over the past few years, we know that Black Americans in America The genetic makeup makes them more susceptible to having kidney diseases. And now that system there in America is trying to hit that target audience and understand how to reach them and how to solve these problems. Can you imagine? It's very unfair for a certain bunch of people who are more susceptible to an illness, and healthcare being very important is trying to reach them. So having personalized medication, personalized ways of communicating to that select people are very, very important, right? Now, the second part that I want to talk about will be the involvement of patients and families in enhancing this diagnostic safety and health systems. Now, everyone needs to work together, more so the healthcare professionals and the patients itself. So let's look at a couple of key elements where patients and families should actively participate in healthcare by asking questions, providing medical histories, and sharing symptoms with healthcare providers. Now, this is very hard to do. We all agree that this needs to happen more often, but it's very hard to do when you have a lot of patients. So this is where I, as a person who works a lot in digital healthcare, looks at tools to take away the burden from the healthcare professionals so that they can have more time. Because if you're looking at paper documentation, it means reading, it means understanding. All these things happen and it takes a lot of time. So when you don't have the time, the patients can't sit down there and provide you with proper medical history, share their symptoms, and ask questions, which is what an ideal system should be. Of course, this would help promote the open communication between the patients, families, and healthcare professions to detect diagnostic errors early and to prompt intervention. We live in Asia. A large part of Asia has the same problem with alternative medication, with supplements that come from various different countries that are very ambiguous in it. And people use this. We all know that people use this. Their family members are selling it. Their family members are promoting it. And there is that peer pressure. I'll tell you that in the 12 years that I have been transplanted, I still have family members coming to me and giving me what they feel is very important for my healthcare. Right? They want to give it to me. They want to sell it to me. And for the first 2 years, I was telling them, I cannot take this. They still don't listen, right? And they still come and they give it to me. So today, I don't fight them anymore. I take the item, I don't use it myself, but I give it away because just taking the item from them makes them feel better, right? Because I've tried for 2 or 3 years telling them that I cannot take this product. I cannot take this because my doctor doesn't allow it for me, but they just don't seem to understand. So this is, of course, me as a patient involving my doctors with this conversation that has helped me be able to ring fence myself across from this issues that can come by using this supplement. So this is again stories that we are telling other patients so that they realize that there is a way out of it as well. Further ideas is obviously encouraging health literacy. Now, these three key elements for enhancing patient safety. One would be to engage with patients. Number two would be to educate them. And number three would be to empower them. That is important. Now, where do we get health literacy from? It comes from you. When I was first diagnosed with end-stage renal failure in 2001, this is pre-Google, this is pre-internet and whatever else. I went to my doctor and I asked him, I need some help. I need to find out about this. He would point me to the volumes of books in his clinic. I didn't understand it. It was very hard to understand medical philosophy or terminology, and I didn't get it. Today, with Google, it's the other end of the spectrum where there's so much of information, right? And you don't know what is right. But if you have a good relationship with your patients, that would help you focus them on what area they need. And you have to look at their education background, understanding the patient, and understanding the conversations that you should be having with them. So this helps the literacy. It educates them. And it educates the larger families as well. So they understand medical conditions, diagnostic procedures, and how to make those decisions for themselves, and also to advocate for it, right? Always, one of the things that we have found is encouraging the patients and families to seek additional medical opinions. In Malaysia, I'm not sure how it is where you are, but in Malaysia, our GPs, our GPs, we have these clinics, little clinics all around us. Those have been our traditional family clinics where fathers and grandfathers and aunties and uncles all went to because you lived in that area. What happens then is there is a trust built over generations. So what happens is sometimes when you're not sure, they go to these people to ask these questions. Now, this is important because these are medical opinions that you know and they trust as well, right? And those are the people, those GPs are the people that know my condition because they've looked at me since I was a little child and I had chicken pox and I broke my hand and so on. So that is a trust built over generations. And so we have to look and work with that, and you have to understand the patient and understand what it is that makes that patient tick in that way. Right. Obviously, another thing is obvious to encourage patients and families to report suspected diagnostic errors, which can help improve healthcare practices and policies. One of the things that I strongly believe in is a no blame culture. So just looking at a situation and say, yes, a mistake could have happened. It could have happened in any part of the process. It could have been from a simple document that was not sent in a proper format, or it was not read. But what we need to do is, if the patients pick this up, they are able to share this and to improve that system and those policies itself. Now, obviously, very importantly, when you do something like that, it means there's a fostering of collaborative decision making. You are involving the patient's family, healthcare providers in a shared decision making. Now, this helps ensure that the choices that a patient makes, the preferences, the situations, improves that overall satisfaction with care. We all have faced times where we have lost people to decisions that were made, whether they were right or wrong. But I have friends of mine whose family and parents are suffering from cancer, but they have decided not to go for chemotherapy, and they have their own reasoning for this, right? And we have to understand and support them. They are totally at peace with their decision. We, as other people outside the situation, may not be at peace, but they are at peace with it. And that is what we want at the end of the day, is to do something like that. Also, families can collaborate with healthcare providers to develop and follow up care plans, ensuring adherence to tests, follow-ups, and treatments. Patients and families can advocate for patient-centered policies, focusing on diagnostic safety through improved communication, transparency, and advanced diagnostic technologies. Now, this is the tools that we're talking about, whether it's digital or not, bringing those into it. But communication is very important, and having communication means that you have enough time to do that, which is important. Also, to advocate on healthcare culture,
Manvir, so sorry to interrupt you, but we are exceeding time.
Okay, I'm going to finish up very quickly. Also, to advocate for healthcare culture, promoting accountability and continuous improvement in diagnostic practices, learning from past errors as well, and family support. Now, family support is very important, enhances emotional, moral support for patients, aiding in navigating diagnostic processes, reducing those anxieties, in improving diagnostic accuracy. Right. I'm just going to end with this one here. You treat a disease, you can win, you can lose. You can treat a person. I guarantee that you will win no matter what. That came from the Patch Adams. I just want to share that with you. And this is my social media. I'm on LinkedIn, Instagram, Facebook, whatever that you want to contact me. As I share, I learn as well. And I hope that you have learned from me. Thank you so much.
Sir, you are on mute.
Thank you, Manvir, for the nice quote to close your presentation. You have emphasized on the accurate and timely diagnosis, as well as the importance of involving patients and their family for the diagnosis and other things. Now we will start with the panel discussions, and we will be talking about the multi-stakeholder perspective, we'll be taking the perspective on the diagnostic safety. You will be focusing on that. And I will request all the speakers to at least be mindful of the time so that everybody gets an opportunity to put their views. They should not be seen that paucity of time is there. So we would be having three back-to-back presentations. One is about the perspective from policymaker. So Dr. Piyawan from Thailand would be sharing her views on that. And we would be having a perspective of the patient organization, Sairekha and one healthcare provider, Janis, would be sharing at this. So over to all of you, please. I will request Dr. Piyawan to give her perspective, followed by Dr. Sairekha and then Janis.
Good evening, everybody. Can I share my presentation?
Sure.
Yes. Okay, sure. Yes, okay. I'm not sure I have about 15 minutes for sharing and learning with all of you. The first of all, this session, this is I will share my experience for the policy driven on the diagnostic safety law of my I'm the CEO of the Healthcare Accreditation Institute. But the hospital accreditation, this is like the one component in the maintenance of patient safety. That is me for the law of the CEO of the Healthcare Accreditation Institute. First of all, I think everyone knows that is the global agenda about patient safety. Since 2002, World Health Assembly urged all member states to move a quality of care to patient safety. But for 17 years ago, found that the no action about patient safety, not no action, have action, but patient not safety is happen every day. This is in 2017, global action on patient safety announced in World Health Assembly and established World Patient Safety Day to motivate and empower all countries to show the activity about patient safety together. And 2 years later, 2021, the DG of the World Health Organization launched Global Patient Safety Action Plan. That is mean motivate all countries move the patient safety action. That is for move policymaker very, very important. And Global Patient Safety Action Plan that toward the law of external evaluation organization, like my organization, the Healthcare Accreditation to achieve safety, we must. Oh, this is my our journey about patient and personnel safety in Thailand. We start about quality and safety since 1997, integrated quality and safety in hospital development for hospital accreditation for a long time. And 2013 to 2015, we launched the bottom-up policy from engagement of all to patient safety program. The first group about the expert to the patient safety education. The second group, the social movement from the patients for patient safety. And the last group engage the all hospital to develop something like a platform to learning, sharing for develop the bottom-up policy to the policy maker. And 2016, my country, but my organization, that accreditation that is the pro about self-assessment. We use the country self-assessment for patient safety and found in our country now have the policy and have something to area for improvement about the adverse event learning and involve the patient joy in the patient safety movement. We when we have that, my Ministry of Public Health announced the national policy. After that, we have the national committee, national strategy, and national goal. And we have the platform to sharing and learning or implementation policy like a 2P safety hospital project. In Thailand, we have patient and personnel safety and launched the World Patient Safety Day in the same all of the country. And 2022, we integrated in hospital standard and criteria for accreditation about safety. For perspective on diagnostic safety from policymaker, diagnostic safety at the mean, patient safety. Diagnostic safety is a critical component of healthcare quality with far-reaching implications for patient outcomes, cost, containment, and public trust in the healthcare system. The patient safety is the absence of preventable harm during the process of healthcare. Diagnosis is the process of care and identify to the patient's health problem and is a key to assessing the care and treatment they need. A diagnostic error is the failure to address a correct and timely expanded for the patient health problem, which can include that you told me that include delay, incorrect or misdiagnosis, that the failure to communication that expand. The diagnosis is the process that start to correct or incorrect treatment. Because the diagnosis, this is if misdiagnosis, this delay treatment, incorrect treatment, and all this the flow. The World Health Organization that announced the death to poor quality. In low and middle income, 8.6 million deaths per year. Only 3.6 million death did not access to the health system. Did not access that it only access, but when access and entry diagnosis very, very important. And 5.0, all people who sought care but receive poor quality of care. Diagnosis is the start area for everything in process of care in the hospital. That is very, very important. The law of policy maker to developing and implementing policy that impact diagnosis safety and quality of care, I think have 4 steps. The first, policy development and announcement. The second, policy implementation. The third, if implementation, must monitoring and continuous improvement. And the last one, policy must future-oriented policy from research, report, and policy recommendation. I will try to talk about 4 steps related to the work in Thailand. The first, policy development and announcement. Patient safety as a core responsibility. This is a priority of patient safety. Diagnosis earlier as the significant source of preventable harm. And then focus on reducing diagnosis error. Because diagnosis error can lead to misdiagnosis, delay treatment, and inappropriate care, and aim to lower the incidence of this error through the targeted intervention and systematic reform. That's in Thailand. We announced the patient and personnel safety goal. In the patient safety goal for the national goal, include the safe surgery, infection, medication, and patient care process, live to and laboratory and emergency response. The safety goal and guide that for the all hospital to select or pick up something to work in their hospital. But we set the priority in the patient care process. In the patient care process, many goals, and one of goal is reduction of diagnostic error. We announced national patient safety goal that included reduction of diagnosis error since 2018. But this is for in general. The next step, we develop policy implementation. If you would like to implementation, creative comprehensive standard, very, very important. Standard for work, standard like a guideline for the hospital, and setting evidence-based guideline for the diagnosis protocol, data report, and quality assurance. And then when you have standard, you must ensuring accountability. Establish oversight mechanism to ensure healthcare organization comply with diagnostic safety standard and accreditation. That is the law for ensure accountability. In my country, we implement or integrated national patient and personnel safety goals and guide in the hospital and healthcare standard in risk management. Moreover, we integrated the diagnosis error in the process of care. Standard for patient assessment, we include the step-by-step for diagnosis and diagnosis investigate. Pay attention that diagnosis, the guideline for all hospitals that patients receive correct diagnosis with sufficient document evidence to support the diagnosis. The diagnosis is recorded within determined time frame and in change when there is additional information. The healthcare team regularly review the accurate and comprehensiveness of diagnosis and consistency of diagnosis among each professional in the team. And very, very important, we propose for the criteria, the organization determine reduction of diagnostic error as one of its patient safety goal with robust data analysis, control improvement, and monitoring. This is the criteria in the standard that promote all of hospitals to work, and we set it is for the criteria for accreditation too. We select some patient safety goal that is very, very important from the data, from information in my country to set the essential standard, that 9 essential standard, and diagnostic error is the one of 9 of essential standard, and included error in reporting laboratory and pathologist test result that it bring to the diagnostic error too, and screening error at the emergency room. The National Patient Safety Goal, this is a critical preventable harm, and we promote enforce major change in the health system, select something for the criteria for accreditation. The diagnosis error, not the criteria only for practice, but the criteria to accreditation too. The third step, monitoring and continuous improvement. Data-driven is policy making very, very important. Using data to evaluate the effectiveness of policy and intervention, and learn from mistake, exhibit diagnostic system, learning system or platform, very, very important for drive continuous improvement across the health system. In Thailand, we monitor that we set the goal about misdiagnosis or delayed diagnosis and monitor the result. Wow, we found 17 deaths from diagnosis error. And misdiagnosis is a priority for sharing and learning to promote and educate together. From this, we have like the poster protocol to promote all of the hospital to take something to improve diagnosis by evidence-based. And we have the platform for sharing and learning with experts about root cause analysis about diagnostic error, both online and on-site, for take intervention on the platform. And for the context, each context is different. The last one, policy makers should do future-oriented policy, research report, and policy recommendation again back to the policy maker. I think consider how future healthcare training ensure that health systems are prepared to handle this challenge. And the second, encourage innovation, create environment to encourage innovation for diagnosis safety, support the research, new tools, process, strategy, and policy from information and research. In Thailand, we study about megatrend, many megatrend that bring to the diagnosis error and try to take intervention. And we use the data that record in Thailand with the expert to analyze data and set the like a policy recommendation and report like a top 10 patient safety issue. And in the report from my country, diagnostic error, that is the topic that's very, very important. We launched this report to promote all hospitals to concern diagnostic error, and back to the policy recommendation for the policy maker again. This is the conclusion about diagnostic error in my country. Trend from 2018, that is the increase, but now trend for the decrease. And we have the contributing factor and we have the recommendation. For example, contributing factor for the hospital, poor communication between doctor and patient, clinician bias, fragment treatment, inadequate staff living level, and lack of diagnostic equipment, overreliance of new technology, and recommendation for policy maker from research, from report, from data, very, very important to policy maker. For example, prepare comprehensive patient information form, ensure patient information is accessed, electronic health record system or digital technique to support for decrease delay diagnosis, wrong diagnosis, and misdiagnosis. Learn from my country, I think global direction very important. Strong leadership and policy support very important. Horizontal and vertical approach very important for approach diagnostic early and engage of all like the owner of system. Network alliance for sharing and learning very important and must have the central organization to main coordination something and support tool and platform for reporting and sharing together. In Thailand, have the handle lack of understand about what is a report, what is the diagnosis, error, time and effort, consider the higher workload. Mindset very important to understand quality and safety. High extreme expectation from patient, family, different stakeholders, and limited funding and resource. The system and expert for analyze, but the key person that is very important for drive or the patient safety or diagnosis early is the policy maker. In Thailand, the Ministry of Public Health is achieving goal and overcoming challenge. He is a policy announcement. He said team building. He support and empowerment. He gives the reward and recognition. He have the visionary leadership. He told that I like a public communication and I change the Ministry of Public Health, the first one, the second one, and the third one. Continue the policy in the same agenda, not depend on the person. This is very important. And on the World Patient Safety Day in my country, the first policy maker, I change the Minister of Public Health again, but he still and continue at the agenda about patient safety. The system very, very important more than the person. Thank you for your attention.
Thank you, Dr. Piyawan, for taking us through the journey which you have encountered and seen in Thailand, right from having an accreditation standard to having a code for this, and how the policy makers are important. So may I request Dr. Sairekha Sureshkumar. So please share your perspective from Indian context. I think so.
Thank you so much. Dr. Piyawan, such a fantastic presentation right there. And Dr. Madan, I have a few years for my doctorate. Miss Sairekha Suresh is plenty. And thank you so much for putting this wonderful event together. I mean, hats off straight off the bat to Pear and my colleagues at the Patients for Patient Safety Network. This is such a relevant conversation. Let me quickly share my PPT as I get started. There'll just be a moment. There you go. All right. So my name is Sairekha Suresh, and I'm an advocate. And in my case, it's literally a pun. I also went to law school. So in my day job, what I get to do, of course, is to advocate rights for everybody at large. But I'm also a person who lives with type 1 diabetes. I conquered the condition when I was 11 years old, and it's now been a very long journey. It's been 3 decades of, living with type 1 diabetes. And a couple of years ago, out of sheer necessity, I happened to be somebody who founded one of the first, upcoming patient groups in type 1 diabetes. Of course, over the years, it's such a beautiful journey for type 1 diabetes, at least, and a lot of other NCDs in India where, there's been a huge meteoric rise, so to speak, of patient organizations, with patient voices in this space. What's really interesting about patient organizations and why they should have a seat in the table is that we're really a motley crew. If you look at, the anatomy of who sits in a patient organization, you're of course looking at, patient-driven patient organizations, but you're looking at other stakeholders like, patient families. You're looking at caregivers. You're also looking at activist groups, patient advocates. You're looking at sometimes healthcare providers who are also interested. So it's a very, very interesting motley group as to, who comes as the voice when you're talking to a patient organization. And again, here's the other side of the coin. We're looking at particular challenges that patients face, in the whole diagnostic diagnostic safety ecosystem. And I'm now here to talk about the India perspective. Of course, when I sat down to list, I promise you it was a universe in a teacup. But since I've only been given 15 minutes, I just picked my top 5. All right. So one of the key challenges that we see in India today are access to affordable diagnostic infrastructure. All right. We also are talking about immense challenges in health illiteracy among, communities of patients. We are, of course, also looking at underdeveloped regulatory environment, at least in the Indian structure. Of course, in the last 5 years, our regulatory environment has seen such a sea change with the new governance, with a lot of laws and, policy that's been happening and that's been created, which has not happened hitherto. However, we still are, in a place where we are a growing regulatory framework, but we're also an underdeveloped regulatory environment. We'll speak more about that in a bit. India also is a country where when we're talking about diagnostic, systems, there is so much of social stigma associated with diagnoses itself. All right. We're looking at, again, a lack of patient-centric approach in diagnostics. So where we have found, and I speak from lived experience, I speak from my own experience where I sit in a type 1 diabetes community. I speak from my shared experience with, my colleagues at PFPSN, where, I'm looking at patient advocates from different NCD groups, whether it's cardiovascular health, whether it's cancer, HIV, thalassemia, you're looking at how each patient organization has somehow found ourselves to, come with a very central role in the diagnostic safety ecosystem, conversationally speaking, all right? Because we are, of course, there at the heart today, at least we're negotiating to be at the heart of the conversations with other patients, families, caregivers. We're looking at, conversations with the regulator, where we're talking to the regulator about policies that influence, patient safety, patient diagnostics, patient experience, things like pricing, things as like access to healthcare. We are in conversations with research organizations, where they're trying to access, patient rights when it comes to clinical trials. We're talking about, talking to organizations for creation of policies, whether it's a school, whether it's a workplace, where patients are either, being educated or being employed as to patient rights there. So we see ourselves in, the heart of conversations with so many multiple stakeholders in the diagnostic ecosystem. And today, my voice to you and, my points to you come from, being in this space and my lived experiences of being here. So when we talk about challenges to access to affordable diagnostic infrastructure, all right, straight off the bat, the one thing that keeps slapping me in the face is India's national spend on health, right? The official statistic to be believed is that we're currently aiming to spend 2.5% of our GDP on health itself. Although if you want really to believe Economic Times or Quint or any of the leading dailies, we've barely met about 1.8 or 1.9% of our total GDP. If you think India is such a large country, look at where other economies are in terms of what their national spend looks like. We're looking at the United States, who averages at 16%. We look at OECD countries averaging between 9.7 and 12%, and we're sub 2.4%, right? So if our share on the spend on public health infrastructure is so little, the share of diagnostic spends, public spends on at least diagnostic processes are even smaller, right? So we don't have a public infrastructure that's robust on, diagnostic frameworks itself. So diagnostic safety straight off the bat goes out of the window. If you have such a small market share of the regulator in the diagnostic space, then of course, the India story. This is the best of times. This is the worst of times, where the private player is who has a larger market share in diagnostic safety. So again, this comes into, when you have an excessive reliance on private infrastructure, first, straight off the bat, it's expensive. It's not price controlled, right? You have unstandardized diagnostic procedures, going on from organization to organization or institution to institution. We're also looking at diagnostic processes that are extremely opaque, all right? And then comes the rural-urban divide in India. And when I say this, it's a very interesting statistic that I came across a couple of days ago, where we say 70% of the diagnostic facilities are, available in urban India. All right. But
only 20% of the customers live in urban India. 70% of actually the key, population of India lives in the rural areas, and only 30 to 30% of, diagnostic facilities available in rural India. So this is like the New York or the Bombay situation where all the offices are in Manhattan or South Bombay, and, all the people live in the suburbs, and, there's this whole access issue where, how do you actually reach the facility? So one of the greatest evolutions, that have happened for patient groups and patient organizations is what I'd like to call the patient provider partnerships. When patient groups started getting formed, we started seeing a lot of partnerships forming with the healthcare provider just to start bridging these gaps. So one of the greatest, movements that have happened is patient groups joining in screening camps. So today, if you see whether it's a Rotary or whether it's any of these patient organizations, you have a screening camps for eye conditions, you have retinal health screening camps, you have diabetes screening camps, you have, screening camps for hypertension, right? So you also have people, assisting, their healthcare providers to go to the length and breadth of the country, whether in urban or rural spaces, to help screen various NCDs today. So this, of course, to some extent is mitigating the access issue to diagnostic infrastructure. But I would say this is, again, a very tiny pebble in a sea, right? There is a lot of ground to cover here. But I do see that, patient organizations, by design, have develop themselves to cater to lacunas in these spaces. Of course, whether it comes to the other challenges like, creation of more spaces, you also see a lot of these think tanks that have come up, which have taken patient organization voices. And, there's a lot of rallying. This is, again, a very small movement in corporate India, and I have line of sight on these in wearing my lawyer hat. But you see that a lot of these organizations liaise with health groups to see how they can leapfrog value in places where there are. So there's a lot of private equity coming in to create diagnostic infrastructure. But again, as long as there is a gap between how much of this market share is, occupied by the regulator or a public infrastructure portal, we're going to be seeing gaps here. The other interesting challenge, which of course is more blatant in India, is health illiteracy. All right. To start off, of course, in India, because of our diaspora, we have such a huge divide between literate and illiterate populations and their access to information to start with. Right. But even among the literate population, and now because of technology and how much it's accessed, all segments of society, we have the real problem of living in the age of misinformation. Most people in India, as we like to say, have gone to WhatsApp University, where, they receive videos or links on, a WhatsApp group, and they sort of start reading it and taking that as the gospel truth. Then you're looking at YouTube school, where, suddenly you come with a blood test and then, okay, my HDL, my LDL is high, my HbA1c is, I don't know, 6.8. What do? People suddenly go to YouTube and start reading videos, and they would much rather follow an influencer than really go to a doctor. And in the recent times, what's really not helping is a lot of these deep fakes that have taken over social media. Like recently, it was out there in the news. This was in the Quint in April, where popular television anchors, there were deep fakes made of them promoting cures for diabetes. So this is a little terrifying in terms of just how much of the information out there is really reliable. And that sort of is, of course, again and again, reiterating the need for people to go to legitimate healthcare providers to really seek their information. But then again, health illiteracy itself is an impediment in this. Again, in India, we have this very unique problem of quacks and religious figures who are pushing for magical cures. And we see this a lot, especially in the NCD space, right? In India, again, because, we have, culturally, we're more prone to, taking what religious figureheads say as the gospel truth. So you see a lot of these Babajis and Sadhujis, promoting cures for NCDs. I'm very, very grateful. Like a lot of patient organizations and, the AIMS rallied, medical boards rallied, and recently Baba Ramdev was, made accountable by the Supreme Court and made to apologize for some of his famous corona cures. But he's not just the one entity. Today, if you just Google diabetes, the first 10 hits you will see are diabetes cure. And of course, there is no clarity as to whether they're talking about type 2 diabetes, which is indeed a reversible condition, or type 1 diabetes or LADA, which is more of a lifelong insulin dependent condition. So there is so much of misinformation out there. And then, of course, there is the lazy preference of Dr. Google, where you'd much rather, and turn to Google for, your real education of health related information. And the real peril for that is today, if you have a rash and you sort of Google, I have a red rash, it could be anything from contact dermatitis to skin cancer. And you genuinely don't have the means to know which is which, right? So over the years, when patient groups started evolving, one of the first projects that I see that patient groups across the board, and I see this in all NCD groups, not just diabetes, I see this in cancer, I see this in HIV, is that patient groups partnered with their providers to create, legitimate resources and materials to sort of spread awareness around different conditions. There were creations of a lot of legitimate platforms on social media. There were creation of WhatsApp groups with focused groups of people who are patients and caregivers to give authentic information. There was a creation of a lot of in-person groups and events, also medical camps, like I said, where patient groups and providers would reach out to various diaspora to spread literacy on health conditions. You see a lot of YouTube pages today where there is a lot of authentic information around how to navigate around a condition, and most of these content, thankfully, at least legitimately created, point you to a medical professional, or it's done by a medical professional.
Sairekha, I'm so sorry to disturbing you, but we are exceeding the time. Can you please start?
Got that? Sure. I'll make it quick. We also have, of course, challenges where we're talking about an underdeveloped regulatory environment in India. The laws are sketchy right now, right? The regulator's role is very small. What's also scary, and I say this from my lawyer hat, is that access to justice when it comes to diagnostic negligence or, unsafe diagnostic practices is very small. Today, you have to go to a consumer court. And India already has such a huge access to justice challenge. We have a burdened judiciary that literally nobody sues, or very small amount of people sue, and their court cases go on for years and years. Social stigma is another huge challenge where people are afraid to face diagnosis, especially in mental health, where people feel that they would be disproportionately impacted, they would be stigmatized, they won't be employed, they won't have marriage prospects, especially in India where arranged marriage is a thing, they won't get admissions in schools and colleges. So people are afraid to actually accept or reach out to diagnosis because of social stigma. Patient groups once again work here very, very prolifically, where by sharing lived experiences and creating safe spaces. Okay. And of course, another concern that we've seen over time is the lack of patient-centric approach in diagnosis. In India, we see a lot of, a lack of what you say is a bedside manner. They say treat the disease and not the patient. But when you live with an NCD, which is a long-term condition, you really should be treating the patient and not the disease. So emotional management to be made a priority is again a conversation that, patient groups seem to be leading. Okay, so the need is, of course, to involve patients in shared decision making, to enhance communication and information trade and trust building, and of course to provide personal and culturally sensitive methodologies of diagnosis. Right. So I just end with my time. Thank you so much. I really would say, if you ask me what is the call to action, please provide for patient representation in decision-making forums, okay? Have a patient group member sitting in advisory boards or sitting in rooms where decisions are taken, and take patient-driven feedback loops in existing policy. Today, if you're a grocery app, you'll ask for a customer feedback. Why don't you do that with your patients, right? So have a patient-driven, do a data-driven feedback loop in existing policy. And of course, please increase patient access for forums for quick and simple grievance redressal. And I see that we will have a very, very effective movement towards diagnostic safety. With that, I'm at time, and thank you so much for having me here. My name is Sairekha Suresh. I'm there on all your social media forums. You can find me on LinkedIn, Instagram, YouTube, Facebook. Gosh, I'm probably like the rest of my lot. I'm always on a device, but reach out to me, and thank you so much.
Thank you, Sairekha, for elucidating on the efforts which you are making and requesting for patient feedback. Though we do have some patient feedback mechanism, but mainly we are using a digital tool. So the digital literacy is one of the biggest challenge with the patients is having. So you have elucidated deeper on the Google thing, the Dr. Google. And the information overload is one of the challenges that the providers they have. We have to see that how the patient advisory groups or the patient support groups, they usually educate the people what to believe, what not to believe, and how much they can rely on the Google. So with this, I will request Ms. Janis to share her perspective from the provider side based on her Singapore experience. Over to you, please.
Thank you. Thank you for the invitation. Let me share my slides and open up my PowerPoint. You all can see my slides, right?
Yeah, it is very visible.
Okay. Good afternoon, everybody. I'm Janis from Singapore. I'm working in National Neuroscience Institute as a advanced practice nurse. Of course, thanks again for inviting me to share about the healthcare providers' perspective on diagnostic safety. Okay, as an advanced practice nurse, maybe not many countries has such a role. Okay, we are given the rights to allow assessments, diagnoses, and even manage a certain group of patients. And we able to identify the correct problems and manage them accordingly is very essential. And the management's involved in giving a diagnosis, managing them, and ordering investigations and ordering the correct medications in our field. So it's very important and crucial in our particular role as well. As we know that diagnostic errors in different settings of care happens in different settings of care in our healthcare system. And this error often creates impacts to our patients, not just patients, but our own healthcare providers as well. So first of all, we need to define what is diagnostic safety, and this refers to the practices, the processes to ensure the accuracy and timeliness of giving a correct diagnosis. And it should be communicated effectively to the patient. So patients must understand what their diagnosis is, okay? And we should focus on minimizing these errors so that we can create a better outcome and improve the processes as well. So there are many types of diagnostic errors, which Dr. Piyawan just mentioned earlier as well. And this will happen at various stages and various encounter with the patients, be it during a sessions with the physiotherapists, during a sessions with the speech therapists, during the sessions with the nurse consultations or the doctor consultations. It can happen anywhere for the diagnostic error. So of course, we have misdiagnosis which we failed to identify what patients has. Delay diagnosis, which means that the diagnosis is given at a later stage and potentially worsen the current conditions. For example, sometimes we mistaken seizures as syncope initially. So this can happen when the real seizure is not being rectified. Okay, patients can be given a wrong diagnosis and wrong treatment will be given. Right, and this will impact because they can have side effect from the wrong treatment itself. Overdiagnosis can lead to unnecessary tests and often increase the anxiety of individuals. And other common diagnosis errors such as underdiagnosis, diagnostic overshadowing, or even wrong error in tests, wrong error in improper test investigations, audit, error in interpretations of tests and results, and also sometimes failure to follow up test results can be a diagnostic error. For example, I'm a neuroimmuno nurse. So if my patient started on immunotherapy and I ordered a full blood count and the full blood count come back to be abnormal, but I did fail to follow up with the test results, and patients will be carry on having the medications with the side effects. Okay, communications failure is one of the error as well, and failure to consider rare diseases and rare conditions. Also, inadequate physical examinations can be a diagnostic error because we fail to find critical findings through the physical examination. So diagnostic error can be significant impact on the patient's outcome. So when diagnosis is delayed or a wrong diagnosis is given to a patient, their condition may progress and there might be potential side effects from the inappropriate treatments given due to the wrong diagnosis itself. So many of these errors may end up with physical harm, and some may lead to life-threatening conditions, prolonged hospitalization stay as well. Some may end up with permanent disability. Okay, and also worse come to worse, there's increase in mortality among this group of patients. So patients with diagnostic error often ended up with longer hospitalization stay, ICU admissions, more frequent clinic visits, and however, this prolonged stay, unnecessary treatments, prolonged ICU stay, or prolonged increase in frequent visits, can have increased costs in our healthcare system, as well as this cost will impact the patients as well. And diagnostic error can often lead to emotional distress among the patients as well as their family members. This will create unnecessary anxiety and frustration, and worse is lost hope and lost trust towards our healthcare system. And this error will also lead to a medical malpractice lawsuit, and this may not have direct impact on our patient's outcome, but this will create stress among the healthcare providers as well as our patients group as well. So I do not need to further emphasize how important diagnostic safety is. Let's go to review some of the challenges for diagnostic safety. So first will be the biases. It can be cognitive biases from the clinicians, from the nurses, or the other healthcare providers. Because we may rely on the initial impressions or first impressions when we take care of this group of patients, and we may fail to recognize that this could be another issue or another diagnosis itself. Some may have their easily recalled diagnosis and did not open to a broader differential diagnosis and other possible causes. We do have incomplete or inaccurate information from family or from patients themselves. Patients may not know what are the important information to say, and they may focus on the non-specific informations, like what we say that they may have poor literacy and they don't know what is important, and we may not focus on that. Okay, communication breakdown can happen between both the patients and the healthcare providers, or even they can between our healthcare provider ourselves. So for patients, sometimes as healthcare providers, maybe I'm one of the culprit, we do not allow them to talk or actively listening to them due to various constraints such as time constraint. However, communications between healthcare providers are also as crucial, such as during the handover time, creating memos to other healthcare providers of let them follow up with other cares. So the information needed in the memo must be very precise and accurate. Systemic issues, like what I say, can be time constraint. The first visit review in Singapore in our normal clinics is around 15 to 20 minutes. Means that we need to ask history, assess the patients, order investigation, come up with working diagnosis, or even sometimes we need to educate and give appropriate management. And this is at the time spans of about 15 to 20 minutes, which sometimes a bit difficult because there's a lot of other patients waiting outside, right? So by deriving this proper diagnosis, I find that it's very harsh for the healthcare provider to just come up with everything correctly, accurately in 15 to 20 minutes. Other type of systemic issues includes patients having to see multiple providers in the healthcare system. Okay, they see the neuro, see the eye doctors. It can be in the same facilities or same institution, same hospital, or sometimes it can be different hospital, different sites, be it private hospitals or government hospitals. And there's no seamless information sharing among these hospitals. And I'm not able to know that whether the patients have been on an antihypertensive before and it's not working. If the patient is not able to tell me that, I may give back the same medications when they admitted in the acute hospital again. So this is some of the challenges we have. Technological limitations can also refer to the inability to access some of the diagnostic tests that what shares earlier. For example, some tests are not available in the hospital. Okay, and some tests are not available in the countries. Like some conditions, some tests for rare conditions are only available in country like UK, which is like in Oxford, in Mayo Clinic, which we need to export the sample out of the country and wait for the results. And often these tests are very high cost. Okay, diagnostic complexity can happen to cases with atypical presentation or disease are very rare. And this is challenging as there's limited awareness of these kind of diseases. And also we may not be familiar regarding these diseases among our healthcare provider. So healthcare educations and training gaps, I find that diagnostic safety has not been very well emphasized or given much attention in our hospital itself. Much attention is given to medication error, readmission rate, or even surgical complications. Okay. So patient-related factors like what I mentioned earlier, where patients are poor historians, inaccurate or incomplete information are given. This can be due to the poor health literacy, as mentioned earlier, as they struggle to understand the diagnostic instruction, the management instructions, or even we need to understand all these things for them. Okay. So last but not least, okay. So policy and system changes can be at organizational or national level. Like what I say about patients should have a copy of their test results using the technological effects. So like in Singapore, we have a system where patients can get their common blood results via an app so that they are well known about their own condition. But these test results is only available if they do their tests in the government, primary healthcare institutions or hospital. This will allow patients to understand their conditions more and improve their health literacy as well. Next will be creating guidelines and protocols to allow healthcare providers to promote certain evidence base of practice which is more standardized. For example, I'm so sorry. I think I was out. I supposed to be in the challenges and the thing skipped. So let me go through some of it again. So sorry. So just now I was in the challenges of healthcare, diagnostic safety on the systemic issues. So technological limitation, like what I say before, is the access of the treatment, right? Available diagnostic treatment. And if we send the test to overseas, it will be high cost, and the complexity of the patients presented with atypical presentations will be difficult to diagnose them. Okay, for the last but not least, there are underreporting, which I think is important to mention, which I think I skipped it just now, is the underreporting of diagnostic error in our institution. I'm not sure in other country will that be such a case as well, because most of the time these diagnostic errors are actually greatly depends on the voluntary incident reporting. So individuals reported or other people may whistleblow and tell us these incidents, or there may be complaints from patients or families. So these are the things that are our challenges in Singapore, which there's a lot of underreporting of diagnostic errors. So how to improve diagnostic accuracy is vital to ensure that patients receive the appropriate treatment and timely care. To improve diagnostic accuracy, we need to address the challenges that I mentioned in earlier slides. And we need to have collaborations with healthcare. I think no need to emphasize more that we need to collaborate with the patients group, as well as the policymaker, as well as the researcher, not just the healthcare provider, the doctors, the nurses, and other healthcare provider like the speech therapists they are. So the first of all, I think interdisciplinary knowledge sharing is a sharing is important because this is a holistic approach where to prevent overlooking of issues, especially on complex cases. So different team members can group together and identify the problems or solutions that missed by another members, especially in the complex cases. The other type of strategies is combining expertise, having a committee of practice. Like our neuroimmunology group in Singapore, we group ourselves up every month to discuss complex cases. So be it you're from this hospital, from private hospital or another institution, we will try to group together as a committee of practice so that we can discuss and it act like a second opinion, cross-checking on diagnosis. And also this will avoid biases and ensure correct conclusion. Patient engagement and participation, empower patients and educate them to improve health literacy. Nowadays, I think health literacy shouldn't be ignored, especially now we are very into health informatics technology. So encourage them to ask questions and have them share decision making by discussing with them the potential diagnosis. Even that you don't know the diagnosis yet, I think it's good to tell them this is the working diagnosis and what are the plan. And this can lead to more comprehensive information gathering as well. Enhanced communications in hospital. Many hospitals, I think not just us, I saw the Thailand group also, we do have SBAR. So SBAR is a communications tool that allowed the healthcare providers to present in a certain way. S will be situation, B will bar, which is the B itself will be background assessment as well as recommendation. This tool is used during handover for nursing, for healthcare provider, or even when we refer to other specialists. Training and
Ms.
education.
Janis, if you could wrap up, please.
Okay, I'll wrap up soon. So training and educations will ensure up-to-date training. I find that it's very important for this particular idea because advanced technology is changing and updating. So healthcare providers like myself, we need to be updated about the new technology, new management, and new diagnostic testing. So for example, as an advanced practice nurse, I need to attend certain hours of education training or conference in a year in order to continue my nursing license. And even we are required to audit us internally on medications that we have prescribed. So other than that, to wrap it up, technology and data is very important because we need to leech on current technology or even artificial intelligence to actually have these seamless records and information sharing in the whole national-wide systems. So policy and system change, like what I said that earlier, that Singapore, they are allowed to have their results just on the app. Creating guidelines and protocols allow the healthcare provider to have a standardized practice. So for example, our hyperacute stroke activations, we do have guideline and protocol to create these algorithms involved in inclusion, exclusion criteria so that we know who should or who should not take the hyperacute treatment. And this guideline will reduce error, especially among the healthcare providers or the junior doctors. So last but not least, which is the culture, which is very important. Learning from the error itself is very important. So I think many departments do have mortality and morbidity rounds, and to have us investigate what happened to the patient's diagnosis error. So by then, this is the end of my slides, and thank you for inviting me again. Thank you.
Thank you, Janis, for dwelling deeper from the provider side. And you have also emphasized on the importance of informing the patients and monitoring all the parameters. Now, after hearing the perspective from all the three panelists, now let us dwell deeper and ask first-hand experience from our patients. See, what are the incidents and what lessons can be learned from that incident? We are having two presentations. I will request both of them to stick to time because we have already overshot the time. So we are having two presentations. One is Arshia and the second one is Clarinda. May I request Arshia Bhandari to please share her views?
Yeah, thank you so
Hi
much.
everyone. Sorry, Arshia. So we've decided to present together. We anticipated a time issue, so hopefully that helps. And over to you, Arshia. Please go ahead.
Sure, thank you. Thanks, Clarinda. So, to begin with, I would like to thank Pear for this opportunity to speak about the patient's perspective, because it's very important to understand how patients feel and what are the patient's stories and what lessons can be learned from there. So, me and Clarinda are going to talk about majorly, there will be personal experiences and also some very relevant patient stories that we will be sharing. Next slide, please. Okay. So before we delve deeper into the stories, I would like to share some startling stats. These have already been talked about to an extent in the previous presentations, but it's always good to see the numbers to really understand, the extent of the problem that we have at hand. So 1/3 of malpractice cases that result in death or permanent disability stem from an accurate or delayed diagnosis, making it the number one cause of serious harms among medical errors. Diagnostic errors affect an estimated 12 million Americans each year and likely cause more harm to patients than all other medical errors combined. So I'm taking here the example of America because in India, there will be extrapolated numbers, but not really, we have an issue with data collection. Roughly 80,000 deaths in US hospitals each year can be attributed to a diagnostic error. It's also about the same number of people who die annually from breast cancer or diabetes. Delays in diagnosing cancer are very common. About 7% of abnormal test results are not communicated to patients, which can lead to a delay in diagnosis. And as Dr. Madan also shared, the catastrophic repercussions that it has when there is a delay in diagnosis. On average, patients with rare disease wait 5 years for a diagnosis, and these are the sources for these stats. Now these are just numbers, unless we give faces to these and see, and unless we know the patients personally, I think we're not able to understand the extent of it. So I would give over to Clarinda to share the first story with us.
Thank you, Arshia. So I would like to share. So these are stories that are real stories. These are real people's names. They've given us permission to share their stories. We have some of our own as well. This is Elizabeth Cohen's story. She is a lady in the US. She developed symptoms of cholecystitis or gallstones, and an ultrasonography confirmed that, but also showed some lesion in her liver. And the surgeon at that time recommended that while they were doing the gallstone removal, it makes sense to also just remove that lobe of the liver that has that lesion. And that was done. And when he removed it, he told her it looks harmless. But then when they sent it for a biopsy, the pathology report said that it's liver cancer. Now, something in Elizabeth told her she can't have cancer because she was feeling fine. She didn't really have any other symptoms. And the surgeon himself was surprised that it was cancer, and he actually recommended a second opinion, which I think is a very rare thing. But the sample was then sent to another state for a test, and that came back saying that it's a benign tumor. That means it's not cancerous, and there's very little chance of it progressing and becoming aggressive. And Elizabeth didn't stop there. She was advocating for herself. So she contacted an expert in the field, told him her case, and also then confirmed that it was actually not cancer. So Dr. Madan referred to a case like this where she would have been exposed to chemotherapy and aggressive cancer treatment because of a false diagnosis of cancer. Right now, she's at a place where she's scared of any routine checkup because of her misdiagnosis. This is Katel Maget. She is a French lady living in the Netherlands. She got her first period when she was 11, and all her life had really painful periods. But every time she went to a doctor for it, she was told this is normal, your pain threshold is not high enough, things like that. And it was only more than 20 years later, when she was trying to get pregnant and could not, that her gynecologist advised for the test and discovered endometriosis. The story doesn't end there. Shortly after her endometriosis diagnosis, she started feeling frequent abdominal pain, fatigue, and started having blood in her stools. She went to her GP, who kind of attributed it all to endometriosis, and
मैडम का भेजा था ना उसी के साथ वो सब लिख चुका है तीनों को
yeah, who kind of attributed it to endometriosis and just gave her paracetamol. She was due for endometriosis surgery, which is when her gynac decided to pay attention to her blood in her stools and advised an emergency colonoscopy, which revealed that she had stage 3 colorectal cancer. And the symptoms were just, they can be similar to endometriosis symptoms, so they were just not addressed. And because of which she had a very aggressive cancer. She's between 2018 and today she's had 7+ surgeries because of radiation. She's menopausal at 40. And her GP and her gynac, who kind of delayed the colonoscopy or didn't even address the other symptoms she shared, they don't have the face right now, and they've not even acknowledged or apologized to her. But now her gynac has told her that she started teaching her case in hospitals as to, how these things should be considered. And these are not just other people. Like I said, we have our own stories as well. And I'll open it up. Arshia, would you like to share yours? Arshia, are you there?
Sorry, I was talking on mute. Okay, since this is a discussion and we are actually posing the questions whether what the misdiagnosis that happens, is it malpractice or just difference in opinion, or if this can be avoided. Now, I would like to share my story. And these are two stories. One is mine and one is a friend's. So one of my friends shared recently that she had missing teeth when she was a kid, around 11 years old, and her primary teeth were not falling out. Because of that, at that time, the dentist who her parents consulted with decided to remove or extract those teeth so that the permanent teeth could grow out. Eventually, the permanent teeth did not come in. She had big gaps and spaces in her mouth because of that, which eventually caused more complications, because of which she had to go for interventions like bracing, which was very, very painful procedure for her. And she said that her childhood was wasted a lot because of these complications. Now and it was I chuckled at it because I had a similar story. I also have milk teeth. And when my parents consulted with a dentist at that time, the dentist took a complete X-ray and an OPG of my mouth, and he ascertained that there were permanent teeth coming from below. And he the diagnosis that he made was of hypodontia, that I had missing permanent teeth. So even if it gets extracted, they will never come out. So these are two contrasting stories where the difference in diagnosis and the intervention really changed the quality of life. The doctor told me to keep the milk teeth as they were, and I could very easily go through life, with that condition. But in a similar condition, and my other friend had had a lot of interventions and painful issues. Clarinda, would you like to share your story now?
Yes, thanks, Arshia. So I have many stories of medical issues because I have a very complicated medical history, but this is one of my first. I was 15 and I was having very frequent abdominal pain and recurrent, and there was we couldn't understand what it was. And my parents took me to a general surgeon who diagnosed it as appendicitis, and I had my appendix removed. And but the pain didn't stop. It continued. And then after seeing multiple other doctors, it turned out to be lactose intolerance, and I was off milk and milk products for like a year or two, and then it just went away. And I didn't know enough at that time, but now that I think about it, I just wonder, it makes me wonder if was it was it really a misdiagnosis, or was it malpractice? Was it a knife happy surgeon? And these are not really nice thoughts to have for a patient to have, because it really can make you skeptical about the whole system. And thankfully, Arshia has a more positive story about a similar case. So Arshia, yours.
Yeah, thanks, Clarinda. Yeah, so when Clarinda related her story, my own story came to my mind. And when I was probably 10 years old, my parents recognized that there was a movable mass at the back of my neck, and they got a little worried. So they went to the surgeon. That was the first course of action they took. We went to the surgeon. The surgeon actually scared us completely. He said, she needs to be admitted immediately. This needs to be removed. And otherwise this could be cancerous. And then, as a second thought to that, because my parents were not ready for something as big as that at that point of time, we went for a second opinion. We went to the pediatrician that, we usually consult. And the pediatrician looked at, that little mass at the back of my neck, and he said, it is nothing. It will go away. It's a usual issue, we see with children. It will go away on its own. You don't need to do any intervention at all. And there the story ended. Now we can understand, where the contrast of the diagnosis there and the contrast of the repercussions of these diagnoses that would have happened. So again, the question that Clarinda posed, whether it is malpractice, misdiagnosis, or difference in opinion, and what can be done really to mitigate this? Can we go to the next slide? Clarinda, before that, would you like to say something?
No, you can go ahead and talk. We'll come back to it when we're discussing the next step.
Sure. So the next one I would like to talk about, and which is a very, very common phenomenon in healthcare practice, and that is prescribing cascades. Just to make you understand a little what this means. So is medicine side effect? We all know that medications have side effects, but is the medication side effect a new condition? Can it be diagnosed as a new condition, or is it really a medication side effect, the ailment the patient is coming to the doctor with? So let's take this one example of a patient with depression. The patient is taking medication 1, bupropion, to treat depression, and she experiences insomnia. Now she goes to the physician or the psychiatrist with her condition of insomnia. The physician adds another pill to treat insomnia that causes new side effects, dry mouth, constipation, and foggy brain. And this is a cascade that keeps on continuing until there is a stop to it, where the physician actually recognizes the side effect as a side effect and not as a new ailment, and takes other measures to control that disease. So it's a very big diagnostic error, where a simple re-challenge or change of the medication could help the patient instead of adding more medications to their profile. And there was a case that I came to from, there was a ADR surveillance, adverse drug reaction surveillance study done in a medical college in India. And it talked about a case where a patient had come with a constant stomach pain, and the patient was put on antacids and pantoprazole for a very, very long time, for almost 7 years. And when they did this ADR surveillance study and further investigations, they came to know that there was a medication, escitalopram, that was being given to the patient, which has a common side effect of stomach pain. And that medication was never recognized as one of the factors. And when they de-challenged that medication, the stomach issues that the patient was having improved. So this is, another very important issue, and it's important to discuss. And I wrote an article for Uppsala Reports, which is a WHO publication, where I talked about do our healthcare professionals need to use the pharmacovigilance lens to diagnose? Because misdiagnosis of a new condition or not diagnosing it as a side effect has very great repercussions and addition of not required medications in patient profile. Can we go to this next slide?
Yeah. So thanks, Arshia. I think that we've shared quite a few stories, and I think that they all link up to what all our previous panelists have said one way or the other. But we'd like to share some high-level lessons and thoughts that came to our mind when we listened to these stories. So the first one, I think, is gaslighting, which is very common, especially for women, or you could say like a paternalistic attitude to the whole thing. This is very common in cases like endometriosis, where really pain, right? Because pain is just not something you can quantify on a universal scale, and everyone has a different threshold, but it's often that women are told, you're just imagining it, you're just being anxious, lose some weight, things like that, and dismissed. So, yeah, Arshia, what would you say are some things that you would advise patients?
So I think it's very important for patients to trust their instincts about their own body. Because we need to, as we say, paternalistic approach. I think this is a very common issue, not just in India, but all over the world, where, patient approach is not really, or that patient engagement in true terms in their treatment decisions is not taken care of. I have a personal experience where I questioned the diagnosis, a psychiatrist diagnosis of a family member to a doctor. And I belong to, I am in the healthcare field. I work in the pharmacovigilance field. So I have that health literacy to, understand medical terms. So when I asked this question, the first question the doctor asked was, "Oh, are you a medical professional? You've gone to Google and you've asked Google about it. And, I don't think you can question my diagnosis." So I think it's very important that patients' views are listened to. I understand that there's a lot of misinformation on Google or other sources of information. So the best way to guide patients could be to, send patients to the right sources of information so that they can take, their treatment decision in collaboration with the healthcare professionals. And I think my advice to the patients is, if you're not feeling, if you feel you're not being taken seriously, it's important to consult another doctor and to advocate for yourself. Again,
yeah, I think that another. Sorry.
Yeah,
I think that another problem is that doctors are often not willing to admit that they don't know or they're not sure, and it was I thought that was very cool that in Elizabeth Cohen's case, it was her surgeon who recommended a second opinion. It's really not often done. Doctors they seem so insecure about a second opinion that patients cannot even go back to a doctor and say that I got a second opinion and this is what I found out, because the doctor is likely to take offense to that. But it's absolutely the patient's right and prerogative to do that, and it should be encouraged. Arshia, would you like to talk about this?
Yeah, so again, I would like to say that before any invasive intervention, I think it's important to get a second opinion. If you're not sure about, or you have that gut instinct that the diagnosis might not be. And these are, I have been talking about patient safety for the last 2 years, and I can really understand these are very complex discussions and issues. There's no black and white in it. There's a lot of gray area, and it's very important for us to have discretion with whatever decisions we are taking. Again, ask questions about the diagnosis and test results. And again, like Dr. Sairekha shared in her presentation, health literacy is something that is very, very important for patients. But before health literacy, I think authentic sources of information that are government. For example, we have EMA websites, we have FDA websites where we have, authentic information on disease areas as well as on the medications. That kind of availability should be there for the patients as well, so that they can directly go to those sources where doctors can recommend them and get that information. So ask questions about the diagnosis and test results. And one needs to have clarity before one goes for any interventions. Clarita.
And then the last point talks to the last example that Arshia shared, which is of prescription cascades, where doctors don't consider the possibility of side effects. And here our advice would be that it's important for patients to tell the doctor their entire medical history, especially their own medications. I honestly have started writing my history and going to doctors. I have a complicated history. I know that the doctor has 5 minutes with me. I know that all doctors will not receive this well, but I actually write timelines. I write what I was on, what I am on, what I have been on, and I go with a long, A4 sheet of paper. And then if the doctor dismisses that, then I know that it's probably time to look for another doctor. But most doctors have been quite appreciative of that, because I want to be taken seriously and I want all my issues to be addressed. Arshia?
Yeah, thanks, Clarinda. Very relevant points there. And this is our last slide. So, just one, my last 2 pence there. So I understand. I've been, since I am in the field of pharmacovigilance, and I've had an opportunity to interact with healthcare professionals and patients. I can see both sides of the coin. So when we talk about medication side effects, we understand that there's a lot of scare that can also be caused if the patients go with the literal meaning of what is written in the medication leaflets, and there can be a lot of resistance in taking medication. So it's a complex issue. It's not as straightforward as that, because the patients might not adhere to medications, and all that problems could be there. A solution to that, of course, is that the discussion about the side effects and exact explanation of what is expected for a particular patient from a personalized point of view. That information is provided to the patient by the healthcare professionals themselves. Or if patients do come with the questions, there is a counseling where healthcare professionals can explain where they need to be worried and not worried. And again, there are, of course, potential side effects. So the initial information when the patient consults with the doctor, that if you see any severe side effects, which could be named there, they need to come to the doctor as soon as possible and needs to be reported to the healthcare authorities as well. Now, these were the points that we majorly wanted to share, and we are open to any question and answers.
Okay, thank you, Arshia and Clarinda, for such eliciting such advice to the patients. Misdiagnosis, we can't say it's misdiagnosis, but the capacity of the medical professional, that's the one question, because the point which you have mentioned, if the doctor is not aware, because I'm just citing an example to take your thoughts forward. During my medical college days, I was diagnosed as having nephrotic syndrome, as I was putting on a lot of weight. That was in 87. I was put on medication, that is diuretics, for almost 1.5 months. But still, it was not improved. But I have taken plenty of opinion. That means second opinion, third opinion, fourth opinion. But during that time, that specialization was not there. Looking at my agony, one of my resident seniors, he took me to his person who was a reader. Then he immediately asked one question: how you are feeling? That's why in the opening sentence I mentioned about the importance of the clinical history taking. He just asked the question, how you are feeling? I told that I'm feeling normal. That it was a hot and sultry weather. That was in Gopal, hot and sultry weather, and it was not comfortable weather at that time. Immediately he just examined me clinically and told that you go and do your thyroid test done. At that time, awareness about the thyroid was not there. And if you look at the textbook, if you are not aware about a particular disease, you are going to miss the diagnosis. That's why one of the important lessons which is coming after discussing and after hearing to all the panelists is, first we have to see that how the capacities of the doctors is improved so that they don't miss the diagnosis or they don't misdiagnose. Most of the time, as you have rightly mentioned, that we encounter that they don't acknowledge, because for the sake of not being aware about that, because they also it's an ongoing process. Every time they have to rebrush their information and knowledge and other things, they have to be updated by themselves. So one of the things way forward which is coming, because I will just announce that, because for the paucity of time, if there are any questions from the attendees or others, they can write it in the question and answer box, and we will try to answer it either in the inbox or we'll reply by email. So coming back to that thing, we say that the advice which has been given is very pertinent and very useful. One of the things which is starkly coming out is the awareness about the providers. That means if they are not aware about a particular condition, or if they have not updated themselves, they will only stick to the diagnosis which they have made. And I am also a witness and have experience of on Portler and this Lasix for 1 month, and you can speak of the plight when I developed a pericardial effusion. Had it not been diagnosed on time, then I won't be sitting here and talking to you. Being a medical student in an Apex Medical College in one of the in the central part of the country, I was there. There were only 6 medical colleges. Now they are having 30 medical colleges there. And the best of the people were there, and the Padma Shri doctors were there at that time. So if you are not careful, if you are not able to, if you are not aware about that condition, you will never diagnose that condition. With as the pharmacovigilance you have mentioned, if drugs are being given, then you should be having the potential side effects. Many of the things which is usually the pyrexia induced by your antibiotics and other things, that kind of condition, nobody bothers to monitor that, and nobody bothers to tell it about also. But you can invest at least 5-10 minutes of the provider side, at least how they can change their practice habits, and at least spend 5-10 minutes. What does a patient want? All the politicians know what the patient wants, except the providers, the politicians, and the policymakers. The patient wants that he should be seen by a doctor. The doctor should talk to him, explain to him. He should give diagnostics, and whatever diagnostics are there, he should be diagnostics has to be done, and the tests have to be done. And after that, he should get medicine. The only 3 things are required from a patient. If we are able to counsel and provide this thing, then we are able to supply that kind of thing. Policymaker, as we have seen the example of Thailand, how the policymakers can make a change, right from having a accreditation parameters for patient safety, taking feedback, having a patient safety code, as well as doing intervention in the interest of the patient. In the health services, we are only focusing on providing services for whom? For the patient. If they are not safe, then what we are doing? That question we need to ask. From the patient perspective also, there are many things. The advice which has been given by the patients as well as from the incident examples, we have to see that the information overload which is there, so much information is available. The WhatsApp information is there, the Google information is there. But we have to create a mechanism how this information load doesn't influence the care-seeking behavior of the people. That information has to be taken in the right perspective, and the patient support groups or organizations, they can allay this kind of fears and other things which is happening. Because medicine is a science and art. The science part, you can get it through Google and other things. Okay, what is there, what is being done. The art part is what not to do, when not to do. As the example which I cited with the lump in the back, and the pediatrician told that it will go on its own, because it's an art. It usually comes by experience and by observing. And we have to always remember that the patient doesn't look at the books and come for the clinics or the office. The books are written after seeing the patients. So every patient is a unique, provided some basics are being taken care. So we have to see that how the provider perspective, provider, they should be having an empathy for the patient, see that how the patient is satisfied and at least whatever fears and other things are there. So that can be elated only by counseling and giving time. So we can always find 5 minutes, 10 minutes. 5 minutes are enough to convince the patient. It's not necessary. If the patient is already prepared, if he is having information, then it will not take much time in convincing that patient and giving the proper guidance to them. But nevertheless, a lot of work is required to be done. So right from the treatment of right from providing capacities to the caregivers, we have to capacitate them so that they don't miss the diagnosis of a person. Even if they miss the diagnosis, at least they should have the courage to say that yes, this something is wrong, as happens in the Western Hemisphere. If they have done some mistake during surgery, they usually come and say to the patient that this thing has happened to this event has happened during the surgery, and we will be watching and doing this thing. That kind of honesty and courage, I think we have to move in that direction and see that how that kind of honesty and courage will come. It's not. And second thing, another thing is if the patient is saying something, we should have an ear for that. Because when we usually teach the pediatricians say that if the mother is saying something, even in the pediatrics ward, if the resident says something and the mother says something, we will listen to the mother because she knows the baby better than any of the residents. And we have to see that how that aspect has been taken. If the patient is saying something, the provider should be trained in such a way that to understand what the agony of that patient is there so that he can address that aspect. Because we are all working for the patients and the patient's safety has to be utmost. They are the main stakeholders and all the people, the ecosystem which is being created is because of the patient's own. So we have to think about their wellness. We have made a very big journey from we used to talk about the disease, we then started talking about health. Now we are talking about the wellness. Now we have to see that each and every individual is a well-being. And while we are observing this World Patient Safety Awareness Week, we see that how we can ensure that how a proper diagnosis, another thing, even if somebody is administering you some diagnostic test, at least we should be asking the doctors, consulting the doctor, saying that why it is required, how it is going to help the diagnosis. And that's our right to ask that. What can't there be an alternative for diagnosing that thing? So people usually don't ask. They think that if they're I live in Delhi, New Delhi. In this, if you go to the South Delhi, the doctor explains everything. The moment you go to the eastern part or the northern part, he will say that you take this and the patient goes. He will not ask anything. That means from the patient side also, we have to create a lot of awareness. So with this, I will stop here. Thank you very much for this opportunity to share my views for all the panelists, Manvirji and the patients. So it was very insightful to, especially the gas lighter thing. That's a very interesting concept which they have given. Rest of the things I know, but the gas lighter thing is very interesting thing. And very happy that this Sairekha ji, it's already in 87, 88, I think you were diagnosed as type 1. Now you have created a group and now you are a role model for the people living with diabetes. And the next pandemic, which in the country like India, which we are facing is diabetes and this hypertension. And you can be a role model for the people how to live with diabetes and lead a productive life. So with this, all the best. Thank you very much. Thanks again. Thank you.
Thank you. Thank you, sir. Thank you
Thanks,
all
everyone.
the panelists for staying with us. We went a little bit over time, but thank you for giving us the extra time. I think we had a very good and productive discussion. Thank you, Dr. Madan Gopal, for chairing the session in such an excellent way. Thank you, everyone, and have a great weekend. Thank you again.
Thank you so much, everyone.
Take
Thank
care,
you.
everyone. See you.
Thank you.
Bye.
Bye.